Okay, I'm going to talk on non-responding DME and what's next for that. Now, you got to understand what is a non-responder of DME. So, less than 5 letters improvement in visual acuity or less than 10% improvement in the central macular thickness or the central subfield thickness after 4 to 5 successive monthly injections of anti-VEGF is actually what is sort of uh, defined as the non-responder, because less than 5% improvement in visual acuity or less than 10% improvement in the central macular thickness. So that's approximately the definition, which is very important to know. And it's the drcr.net which actually defined this difficult definition. So the protocol I and the protocol T, which were the two important drcr.net studies besides others, showed that nearly 40% eyes had a problem, and there was persisting edema in 23% eyes in the protocol T group in the Rise and Ride study. The protocol I showed persisting edema in about 40% of the eyes, and the protocol the Rise and Ride showed that there was a persisting edema in about 23% eyes after 2 to 3 years. So you have to understand that both the important studies showed that there was a persisting macular edema. The causes of non-responding edema can be poor glycemic control, that is systemic factors, nephropathy, so elevated serum lipids, hypertension. They're all important factors. Extensive hard X-ray, especially clustered towards the fovea, inadequate laser in PDR have all been contributed to the non-responding edema, because sometimes diabetic retinopathy actually goes up to the periphery. So if you don't get laser up to the periphery because the ischemic areas may still stay, uh, that can produce VEGF, that causes VEGF production in the periphery, which causes macular edema. Tractional DME is another important condition in which you have to identify on OCT, and if you do pick up you can do the dynamic focus and DF, which is there in some of the subsource OCTs like the TopCon. So you can see the vitreoretinal interface. If there's a tractional element, that may be a cause of the non-responding DME. And so is the case for vitreomacular traction, thick taut posterior hyaloid, which is so commonly seen. The hyaloid tends to thicken and becomes opacified, and this pulls on the macula and causes unrelenting edema. And I just mentioned that wide field angiography is of great help, and it sometimes helps you to pick up peripheral retinal ischemia, which causes VEGF release and VEGF release and subsequent indirect macular edema. So ACCORD study was an important study, which actually about 7, 8, 10 years back told us that glycemic control and dyslipidemia control can forestall progression of DR in patients with type 2 diabetes, and it treats non-responding edema. So this is a systemic factors. The study which actually contributed, and also the published study told us that it is important to have a good control to treat conditions of non-responding edema, because sometimes these patients, like in the COVID period, they went out of control, many of our patients, and it's happened all over India, probably all over the world, when patients didn't have their diabetic control in place when the COVID was there, and they just stayed inside without realizing that, without any physical exercise and without getting their checkups. So lipid, renal functions, anemia, all that can also contribute. So neurodegeneration is a very important condition for non-responding DME, and suddenly you get this outer retinal tubulation, which is actually the degenerated photoreceptor outer segments. And even as Dr. George Grosha also mentioned, the hyperreflective foci and the loss of the inner outer segments, inner segmentation of the central 1 millimeter. So all these biomarkers, especially presence of ORT is a significant pointer towards neurodegeneration. So diabetic retinopathy is not only a vascular disease or of the retinal microangiopathy or causing microangiopathy, it is also a neurodegenerative disease. So you have a patient who's got recalcitrant or non-responding DME. He's got a little ORT over here, and he's got multiple HRF. So you give the injection and still he doesn't improve. So this is a non-responding DME. So ultra wide field angiography really helps you to pick up peripheral lesions which have ischemia, and that can be lasered. Laser has an important role in non-responding DME, because if there's a peripheral ischemia. There's an ongoing DRCR.net realized the importance of wide field angiography, and they brought out a trial, the protocol AA, which is an ongoing trial, and it's comparing the ultra wide field fundus imaging to the ETDRS7 standard fields imaging for the assessment of DR and prediction rates of worsening of DR. So this is a case which is showing a 49-year-old male. A1C was 8.6, uncontrolled, DM 15 years. VDR showing extent of laser done, augmentation required. So these kind of patients not only learn DME but also traction elevated retina. So you can see the lasers being done here, but because the edema, if you do the fluorescein, actually the fluorescein tells you the ischemia and the unlasered retina. So when the hemorrhage cleared up, this is the extent of laser which needs to be done. And the wide field actually tells you how far periphery you have to go. So it's important to find the cause for the poor response for non-responders. Individualize the treatment for each patient. It's important that you can't have a blanket treatment, same for each patient. And utilize combination therapy wherever possible. So targeted retinal photocoagulation has a major role, and wide field angiography tells us that there's an increased 3.75 times increased odds of having DME compared with eyes without non-perfusion. So if you've got retinal non-perfusion on wide field angiography, it's a 3.758 times increased chance of having DME. Because once you treat the peripheral laser with peripheral laser, you have decreased requirements of VEGF. Ultra wide field, we also presented this in the RO, and one of our senior residents had gone and presented the poster, and it's ultra wide field angiography. And we had done this as a project, and we did targeted laser photocoagulation of the eyes of those portions of the retina which were ischemic. It's actually the healthy retina is not to be treated. So the concept is now that you don't treat the healthy retina, cause dark adaptation problems and color vision problems and accommodation problems, but rather treat only the ischemic, unhealthy or the diseased retina. So this is, we've targeted the ischemic areas only with the Pascal laser, and the Pascal laser really helps to treat only, you get multiple spot patterns and pattern scan laser, and you can treat the ischemic areas only. There's another treatment which is there for non-responders, which is after anti-VEGFs, after steroids, after control of diabetes, after peripheral laser. You also have in your hand another option, which is subthreshold micropulse laser. It's got a partial, probably some role, and it may be an adjunct to the standard of care, which is already there. So it's not going to be a primary treatment. It may have a stabilizing effect on the visual acuity. More work needs to be done. The role of steroids is very important. It's as a combination therapy or even as a primary therapy or a second tier treatment. Patients, especially are pseudophakic and not suffering from glaucoma, are ideal patients. So dexamethasone implants are there, and we've also injected many of these. I've done a lot of these non-responders with DEXA implant with very satisfactory results. The role of PP is always there, and because of which is the last I would say the last option which you will have in the various treatment modalities you have with you, and it removes the inflammatory mediators. It probably increases the oxygenation to the macula, but it's got a limited role because eyelid peeling may cause more damage also. So these are the kind of cases which can be taken up with a vitreomacular traction. So if there's a vitreomacular traction, I'll just show you 2 seconds time. My time is up, so I'm just finishing in 2 seconds, Professor Vishali. So this is just to peel off the central hyaloid. Thank you.